Okay, let's just dive right into this explainer. If you're an ER doc, a neurologist, a nurse practitioner, or really any kind of clinical officer, this one's absolutely for you. Today, we're dissecting the brutal reality and the evidence-based management of cluster headaches. We're going to step totally away from the textbook and right into the clinic to look at the real, practical, case-based nuances of diagnosing and treating literally one of the most agonizing conditions known to medicine. So picture this. Imagine walking into your exam room right now. You expect to find your patient sitting quietly on the exam table, right? Well, instead, you find someone who physically cannot stay still. I mean, they're rocking back and forth, maybe pacing the floor, just gripping the side of their head. They'll describe this excruciating, sharp, stabbing, ice pick kind of pain right behind their eye, and the pain is so intense, it's actually frequently called a suicide headache. To put that into perspective, up to 64% of patients in one case series actually reported suicidal ideation during attacks. That's the sheer intensity we're dealing with here.
And honestly, that perfectly highlights our first major clinical pearl. It's all about the behavior. Think about your migraine patients. They'll almost always retreat to a dark, quiet room, trying to lie perfectly motionless because any movement or light just makes the pain worse. But a cluster headache patient, the exact opposite. They are pacing, they're restless, they're incredibly agitated. If you've got a patient with a severe headache who just cannot sit still, cluster headache needs to jump right to the very top of your differential.
Now, along with that agonizing unilateral pain around the eye or temple, you absolutely have to look for cranial autonomic symptoms. And these are going to be ipsilateral, so right on the exact same side as the pain. You're basically looking for a partial Horner syndrome. You'll see the ptosis, the meiosis, but here's the kicker. Without the anhidrosis. So instead of a dry face, you might see unilateral facial sweating, along with some really intense tearing, severe eye redness, and unilateral nasal congestion or a super runny nose.
What makes this condition truly fascinating, though, is the actual rhythm of the attacks. I mean, these are not your slow-building tension headaches. No, they ramp up remarkably fast, hitting maximal intensity in literally minutes. If left untreated, a typical attack will last anywhere from a minimum of 15 minutes up to about 180 minutes, and they strike repeatedly in these clusters. That means a patient might have an attack every other day, or they could suffer through a debilitating 8 separate attacks in a single 24-hour window.
When we step back and look at the epidemiology, it's pretty rare, affecting just about 0.1% of the general population. But the demographic profile is incredibly distinct. It heavily skews male. We're talking a 3-to-1 ratio here, and typically peaks between 20 and 40 years of age. Oh, and there is a massive prevalence of concurrent tobacco use. In some observational reports, up to 88% of these patients are chronic cigarette smokers. Pretty staggering, right? So, why exactly does this happen? The exact pathogenesis is definitely complex, but the most widely accepted theory actually points to the brain's internal pacemaker. We're talking about structural and functional changes in the hypothalamus. That primary hypothalamic activation then essentially triggers a secondary activation of the trigeminal autonomic reflex. And that chain reaction perfectly explains both the severe trigeminal pain and those prominent autonomic symptoms we just covered, not to mention the very specific circadian rhythm of the attacks.
Understanding that rhythm is absolutely key to building your diagnostic framework. Cluster headache is the most common of the trigeminal autonomic cephalalgias, or TACs. But to nail the diagnosis, you've got to differentiate it from the others, and it's all about duration and frequency. Notice how the attacks actually get progressively shorter, but way more frequent as you move from cluster headaches over to paroxysmal hemicrania, and then finally to SUNCT and SUNA, which can happen a mind-blowing 200 times a day.
So let's apply this in a practical way. If you've got a patient presenting with similar unilateral pain and autonomic features, but their attacks are only lasting, say, 2 to 30 minutes, and they're hitting 10 to 40 times a day, you need to shift gears and think paroxysmal hemicrania. Why? Because this specific condition is completely defined by its absolute response to therapeutic doses of indomethacin. Literally, a trial of indomethacin will just completely abolish their symptoms. It's a real game changer.
But here is where we have to be incredibly careful. Having a textbook clinical presentation and a physical exam, that is simply not enough to end your workup. You absolutely must order an MRI of the brain with gadolinium contrast for every single suspected cluster headache case. Why? Because secondary structural causes can, and frequently do, mimic this exact disease presentation. Yes, even in patients who have a totally normal, pristine neurologic exam. You've also got to actively screen every single headache patient for those SNOOP 10 red flags. For instance,
If you're seeing a 55-year-old coming in with a brand new, sudden onset severe headache, you have to treat that as a structural lesion, an aneurysm, or a hemorrhage until proven otherwise. Never, ever just assume it's a primary headache disorder if atypical features or an older age of onset are in the mix.
Specifically, that MRI you ordered is hunting for some highly dangerous mimics, things like a pituitary adenoma pressing on the cavernous sinus pathways, or maybe a carotid artery dissection. Those can absolutely present with unilateral temporal pain and a partial Horner syndrome. Catching these structural mimics early? Well, that changes absolutely everything about your patient's prognosis.
Okay, so assuming you have confirmed the primary cluster headache, let's get into the treatment protocol. Whether you are working in the ER or an outpatient clinic, you need to remember this one absolutely crucial rule. Do not give these pacing, agonizing patients standard painkillers. Acetaminophen, NSAIDs, opioids, they simply will not work. Prescribing them is only going to delay proper care, prolong their agony, and honestly, set them up for medication overuse headaches down the line.
Instead, you want to switch immediately to an evidence-based acute abortive workflow. Your first move? High-flow 100% oxygen at 12 to 15 liters per minute for 15 minutes using a non-rebreather mask with the patient sitting upright. It is remarkably effective, and it completely lacks systemic side effects. Now, if oxygen fails, or hey, maybe you're in a setting where it just isn't readily available, you move directly to subcutaneous triptans, like sumatriptan 6 milligrams, or intranasal triptans.
Now, if you do opt for an intranasal triptan, there is a vital anatomical trick you really have to employ here. You must physically counsel your patient to spray it into the contralateral nostril, meaning the side opposite to the pain. Why is that? Well, because the ipsilateral side is very likely blocked up by severe disease-induced rhinorrhea and nasal congestion. If they spray it on the painful side, it'll just completely prevent the absorption of your abortive drug, and we definitely don't want that.
All right, once that acute attack is successfully aborted, your job still isn't quite done. You have to classify the patient's pattern as either episodic or chronic, because that dictates your entire long-term prevention strategy. Episodic means they're having bouts separated by pain-free remissions that last at least 3 months. Chronic, on the other hand, means they suffer through attacks for over a year without any remission, or their remissions are incredibly brief, lasting less than 3 months.
Here's the thing. Abortive meds only stop the current attack. They don't stop the overall bout. And since preventative drugs take weeks to actually start working, you need a bridge strategy. On day 1, you want to hit the cycle hard with a rapid oral prednisone taper, while simultaneously initiating your long-term preventative, which is usually Verapamil. The steroids basically suppress the attacks while you wait for the Verapamil to fully kick in.
Verapamil is really your first-line prophylactic weapon, but you must titrate it aggressively. You typically start at 240 milligrams a day, but clinical experience shows us that a lot of patients actually need up to 960 milligrams a day to get the full prophylactic benefit. And because you're pushing the dose that high, obtaining mandatory ECG monitoring to check for heart block and bradycardia, that is absolutely non-negotiable.
And just to give you the specifics for that steroid bridge we mentioned, you'll start with a pretty hefty 100 milligrams of oral prednisone once a day for 3 to 5 days. That's to rapidly suppress those agonizing attacks. Then, you carefully taper the dose down by 10 milligrams every 3rd day. This approach covers the patient safely and comfortably, while that Verapamil dose is being carefully titrated up.
Now, what if the Verapamil just isn't tolerated, or it completely fails? Well, current guidelines now support using galcanezumab, which is a CGRP monoclonal antibody, specifically as injections for preventing episodic clusters. For the chronic, really refractory cases, carefully managed lithium, which obviously requires strict serum monitoring, or topiramate can be used as highly effective adjunctive therapies.
So I want to leave you with this thought. How many patients out there right now are just pacing in the dark, misdiagnosed with recurrent migraines or sinus infections, given opioids that just don't work, and desperately waiting for a clinician to recognize their symptoms and prescribe some simple, life-changing, high-flow oxygen and Verapamil? Recognizing this presentation instantly could literally save a patient's life from the suicide headache. So keep these clinical pathways sharp, and we'll catch you in the next explainer.